Hi, everybody. We'll go ahead and get started. It looks like we still got some people joining, but welcome. So I'm Jeff Burns. I co-direct the Alzheimer's Disease Research Center, and I thank you all for being here. Today, I am going to talk about preventing dementia, give you a kind of a whirlwind tour of preventing dementia and what you can do with your patients and how to talk about it, et cetera, and then hook them up with our resources if it's appropriate. So, but I'm glad today is my day because of the news this week that you probably heard about on Alzheimer's disease and a study drug that's out there on the horizon. So I'm going to start with that. So I'm going to spend, we got a lot to cover. I'm going to spend probably 5 minutes on that, and then we will spend about 15 to 20 minutes on prevention. So, the drug that hit the news wire Tuesday night is lecanemab. And this is a drug very much like the one that was approved in June of last year. It's a monoclonal antibody that targets amyloid. So it's very similar to Aduhelm or aducanumab, although it's given every 2 weeks by infusion. And so the study was results that were published. Basically, this is what we know right now. It comes from a press release. But the top line data, meaning their quick analysis of the primary and secondary outcomes, all hit in the sense of in the right direction. They moved in the right direction or slowed in the right direction. So this is a big deal. We're going to argue about how big of a impact, what's the clinical significance of this slowing, but to see basically the primary outcome, which is the CDR sum of boxes, which is something we use all the time, and is a pretty important scale in terms of measuring functional and cognitive decline. That's slowed by 27%. We haven't seen all the data, so it's a little hard to say, is that really significant? It's about a half point on this 18-point scale. A half point can be a big deal early in the really mild forms, and a half point can also be pretty insignificant in the later stages. These patients were early patients, so it's going to be interesting to see where they were at the start of the trial and how fast both groups moved, but the difference in change was a half point. So that's a big deal. The secondary outcomes, all of them also were met. So amyloid was reduced as expected. This drug targets amyloid and tricks the immune system into pulling it out of the brain. There was slower decline in cognitive performance on the ADAS-Cog and something called the ADCOMS scales. Those are important scales that we use in almost all these big trials. And then it slowed decline in activities of daily living from using a well-known scale of activities of daily living. So, on the surface, this looks very important. Of course, we don't have the details yet. And this is a press release, so we have to be cautious. And then the other key point is the adverse events. And the one we worry the most about is called ARIA, amyloid-related imaging abnormalities. We see edema and we see microhemorrhages in a proportion of patients who get these drugs because there's amyloid in the blood vessels for many patients, and stimulating the immune system to pull that out can trigger edema and microhemorrhages. And so they're reporting at about a 20% rate. That's a little on the surface, again, a little bit lower than what we were seeing with the other drugs that we've tested, like Aduhelm and donanemab, which is another drug in the pipeline. So it appears pretty acceptable in terms of adverse events. And of those 20%, not of those, of all patients, only 3% had symptomatic ARIA, which it seems on the surface a little lower. So on the surface, in a press release, pretty encouraging results. So, what are the implications? I think it's important to know that this is not a cure. This is the first drug where we're seeing this kind of clinical impact, especially with this mechanism of action going after amyloid. So it's not a cure. It's not yet FDA approved. So we can't give it to patients. We can't prescribe it yet, and we're getting lots of calls and emails about, trying to get in to get this drug. It is not yet FDA approved. There may be approval there's likely to be an approval coming in the accelerated pathway, which is not full approval, by January. We do suspect, I think, from just the surface level data, that this will likely lead to full approval, unlike Aduhelm. So, full traditional approval. And then, one thing to note is Medicare did decide sort of across the board that this therapy, they would not pay for it unless it was done in a research setting. And so right now, Medicare is not paying for these types of drugs. And so, we expect they'll think about that again, but we have no idea. This is pure speculation. So, but I'm sort of suspecting that by, maybe summer, we may have access to this drug and Medicare may cover it. But again, pure speculation. So we will get more data at a meeting in late November. So by December 1st, more data, sort of detailed data will come out or be presented publicly. And I guess the only, stay tuned. But what I'd tell your patients is it's not a cure, but it does look promising. It's not FDA approved, but it may be, and it's likely to be, and it may be an option in the next year, 6 months to year. So that's sort of the overview. And I do want to point out that we are using this drug lecanemab here, and in one of our studies, it's a prevention study where we're testing for the presence of amyloid in healthy older adults. And when we see that, we enroll them at a low level. We enroll them in the trial, a 4.5-year trial, giving this drug lecanemab once a month to see if we can prevent decline. So really, really innovative, prevention study using this drug. So it's pretty exciting to see this kind of result coming out in people with mild cognitive impairment and Alzheimer's disease, this impact on clinical measures. And so we're hopeful that, someday we'll be able to prevent it, which leads into the prevention talk. So, so where are we headed? I'll sum it up this way. We're headed, we hope, and we're working really hard, and I hope you can see how we might get there, through trials like that AHEAD study. We're headed to a world, I think, where we'll detect Alzheimer's changes very early, before the onset of symptoms, and we'll be able to do things to delay, halt, or reverse the process. That's where we're headed. We're working extremely hard to get there, and I think we're going to get there. If you have patients, I'll just this is our advertisement here. We want, if you have patients who are interested in this, please, give them information on us. The best way for them to hook up with us is to sign up for our My Alliance program, My Alliance for Brain Health, which is basically it's a newsletter, email newsletter that hooks people up to all the things we're doing, the trials, the educational resources. I'll talk about some of those, et cetera. So once a week, they'll get an email with all this information that hooks them up to it. So, and then we want to stay in contact with you, and a good way is through talks like this, and then our Memory Minute for clinicians. So where it's about a monthly newsletter that we'll send to you guys. So back to the idea of prevention. I love this figure, which shows decline in deaths related to coronary artery disease over 60 years, beginning in 1950, and the red line ends in 2010. But what's amazing is that decline, that sustained decline in cardiovascular deaths, that's been happening. And it's been happening because we understand the risk factors, which we learned in the 60s. Didn't know what the risk factors for coronary artery disease were. We developed drugs based around those risk factors, like high cholesterol, et cetera, and then lots of trials and research, basically everything coming to bear on this idea of preventing coronary artery deaths. And I like this figure because I believe we are, the field of dementia and Alzheimer's is sitting in the 1970s, where cardiology was in the 1970s. And we are beginning to bend the curve, and we're doing it in a lot of different ways. But lifestyle is one really important factor. Even if we have drugs that are going to slow the disease or maybe even stop the disease, lifestyle is going to be a big part of our fight. And we're learning a whole lot. At this point, there's really 12 strong risk factors that may prevent or delay up to 40% of the world's dementia. So the risk factors that are spread across the lifespan, from education in early life to hearing loss and hypertension and obesity in midlife to smoking and physical inactivity and diabetes in late life. So so these are pretty well described, pretty strongly associated with Alzheimer's disease. And there's something that we believe it's, it is time to get very ambitious about working to prevent these risk factors and working to prevent through that dementia, and working at the individual level, at the patient level, but also at the policy level and the population level. And we're actually doing this in a couple different ways. In March of last year, this came out. American Heart Association published this paper, which I love because it basically tells that story. It is time to start moving this information into action. And it's not too early, to be talking with our patients and thinking about blood pressure control and diabetes control, but also exercise and diet and brain healthy lifestyle. And so we've been focused on that. Our Alzheimer's Disease Research Center, our scientists, our researchers, me, we've got our program built around ideas that revolve around lifestyle and metabolism, which is influenced very much by lifestyle. And our scientific sort of theme, which we contribute to this network of 33 nationally designated Alzheimer's centers, our unique theme is really metabolism and lifestyle. And so you can see the map here. There's 33 in the country, and we fought to get into this club in 2011. Took us 7 years of work. We got in 2011. We had to knock out a site. Michigan and Duke lost their sites that year. It's a really competitive process. Every 5 years, we're back up for renewal, and we're recompeting. And we're in our 12th year, and we've just grown tremendously. And it's really fun, and it's an honor and prestigious, to be a part of this club. What it means is we have a whole lot of stuff going on the research side, on the education side, on the clinical care side. But again, we really focus a lot on metabolism and lifestyle. And here's some examples of some of the studies we're doing. I'm not going to get into them. I don't have time to get into them, but things like ketogenic diet, which we're recruiting for right now. But the idea of, can we boost metabolism or improve the health of metabolism, and that will that translate into health gains? We've done a series of exercise studies, which we believe show, they don't quite prove it. We're working on big exercise trials right now to be more definitive, but we believe it's that I think most people accept this now, but that exercise has brain benefits. It's modest. It's not a cure for Alzheimer's. It's not a cure, it's not going to prevent or wipe Alzheimer's off the face of the earth, but it does have modest brain benefits, even at low doses. Come back to that. But we just need to push our heart and lung function and have gains in cardiorespiratory fitness. That we believe then translates, or that's a right sort of threshold to achieve brain benefits. There is some evidence that we may see some slowing in the Alzheimer's related decline in memory and brain atrophy, although we don't see changes in amyloid build up in the brain. But we do think that metabolic and neurovascular effects of exercise translate into benefits of the brain. So we're doing a lot of the work in that area. So when you hear about exercise and brain health, we're right there at the forefront of that. So, but we believe prevention works. And, another way to think about it, it's not going to cure Alzheimer's. It's not going to, get rid of it. But it does, we believe, postpone the onset. If somebody's destined for it, it may move that back in time. And that, if we could move it back in time across the entire population 5 years, we'd cut the incidence in half. So things like exercise and diet can have a big impact in terms of population health. And so, so we sort of preach. We've created a program called LEAP that preaches these ideas about exercise and helps try, motivate and try to translate into daily life the things we're learning in the lab or the things we're learning in our trials. And we push exercise, diet, stress management, social engagement, cognitive engagement, and sort of healthy sleep patterns and healthy sleep quality. And we do that. We have a program we call LEAP that stands for Lifestyle Empowerment for Alzheimer's Prevention. We created this to answer that question for people that we just got continually is, what should I be doing? What should I be doing to reduce my risk? What should I be doing now? And my answer used to be, join one of our studies. And I finally people didn't like that. And finally, we wrote a book, created this LEAP program, and it's really an important part of our program because it's sort of the public facing prevention side of our program. And so we have always we have ongoing classes, and we're innovating new things, trying to listen to what people want. And right now we're in the middle of our Mediterranean diet course with really good, these are online courses, and we will start doing some in-person ones again soon. We have our brain health boot camp that basically covers everything, and that one is starting soon. So again, we built this for patients, families, and for the most part, it's free. I think these are absolutely free. And then there may be some other things. Actually, pretty much everything we do now is free. So it's here for patients, families, and for you to leverage for your patients if you see that as appropriate. And the best way to do that would probably be to refer them to our My Alliance program, or just have them look us up online. But let's come back to, what do we tell our patients? You probably all have gotten pretty good at this. But it's exercise, improve your diet, sleep well, keep your brain active. There's more to it than that, but that's kind of what I walk through. As I say, stay active physically, focus on your diet. And I'll talk a little more specifically. We don't have a ton of time, but get good sleep, avoid sleep apnea or treat sleep apnea, and then stay active, keep your brain active. And so with exercise, the right amount, any is better than none, of course. So going from nothing to something is your biggest bang for your buck. So getting started, and then, creating a habit. I tell people, go out and do 10 minutes a day, at least. But when you're not feeling like it, just do 10 minutes, but do it every day. Keep that, you got to shrink the change, right? But keep it simple. And, but what we want is, really what's been shown to be helpful, most helpful, is 150 minutes. So 30 minutes, 5 days a week. We studied 75 minutes a week versus 150 versus 225. And we found 75 minutes a week had benefits to the brain, but more was better. So, so that 75 minutes, that's 10 minutes, 7 days a week. So, so I think, keep it simple for people, but be encouraging. And I think, small change is better than none. So in terms of healthy eating, what is our definition of a healthy diet? It's the Mediterranean diet pattern. It's not a restrictive diet, it's a pattern. And so, it's vegetables, fruits, whole grains, healthy fats like olive oil and avocado, lean protein, and limited processed foods and sugar and white bread and stuff like that. So so shifting to a Mediterranean diet. It's not a restrictive diet, but it's one where we want to kind of shift to this more Mediterranean style. Sleep, 7 to 9 hours is good. A whole lot is not. A whole little is not. So, and then high quality sleep. So we need to be worried about sleep apnea and looking for it and screening for it. Melatonin is a night. If you can just use melatonin, that's great. And then, so sleep referral if you're worried about sleep apnea. And then, what about brain activity? Should I be signed up doing online games? And we get that all the time. I tell people it's not going to hurt unless you're paying a whole lot of money for it. We don't really know how big of a real world benefit it has. We don't really know if it prevents Alzheimer's. We know if you train in something, you're going to get better in that something. But it may not translate into that real world benefit, but we think it's good. I tell everybody, stay active, read. If you like crosswords, do it. If you don't like crosswords, don't do it. They won't pick it up. So do what you like. But read, be engaged. Social activities are great. But it's important to keep your brain active. So, our goal, our ADRC, we have a goal. We want to, speed the impact of these things we're learning and maximize the impact of these things. And so, we think, again, prevention is achievable. We need more understanding on the individual level. We need to scale up to the population level. That's how we're going to get to, where cardiology is now. We have ideas, we're testing them. We need to apply them to a larger, broader population in the real world, as opposed to bringing people in and studying them here. And we're working on that. We need to package this stuff better, things like exercise and diet. That's why we've created the LEAP RX program. if exercise and diet work, we aren't using it well. We, meaning physicians and sort of the healthcare industry, we need to package it. We're testing this in various ways. One is, best practice alerts where people can be referred or prescribed the LEAP program. We're studying that right now. And we have we actually are analyzing the data now after 6 years probably of doing this. But the idea here is create a tool for clinicians to press a button and refer them to the program. We do see at 12 weeks a little boost in cardiorespiratory fitness. So in those who are referred. But also, how do we know blood pressure is good for the battling hypertension is good for the brain. So if we don't treat hypertension, that's a higher risk for Alzheimer's. If we treat it aggressively, we see lower risk of mild cognitive impairment. And so we've created a health system-wide approach to referring patients automatically via the health record via our fancy computers, identify people and refer them to a pharmacy team and home monitoring using home blood pressure monitoring tools. And so basically the primary care docs team expands and blood pressure is aggressively treated. We're using that to kind of scale up this idea. I won't get into this, but scale up the idea of if blood pressure control works to prevent MCI and dementia, we as a health system need to use it. And so we're harnessing the health system to really make this more actionable and apply it to the bigger population. And so we're just getting started, but you can see some of these ideas and how we're using them. But we think we're already having an impact. Dementia incidence is decreasing. These lines are sloping downward. What they mean is an individual today at a certain age, say a 90-year-old today, is at a lower risk of developing Alzheimer's than somebody 30 years ago, a 90-year-old 30 years ago. And so we are starting to see some change in dementia incidence, and we haven't really even started. So this is hopeful sign that we're on the right track, and that we're beginning to bend that curve. So just two more slides. One is back to this one. We are creating these. We want you to, we want to be a part of your team. We'd love it if you're a part of our team too. And, in fighting Alzheimer's and dementia. And so we're creating things like the My Alliance for Brain Health program, and the Memory Minute to link up and network better, and things like this program, Pocket Talks. So refer your patients here. We don't need to see people in the clinic for them to get involved in research. In fact, we prefer not to. So our clinic is overwhelmed, but we're working really hard, and we are here for you. But we do not need to see your patients unless you want us to in the clinic. They can come straight to our research and they can sign up for this My Alliance. So keep that in mind. And then I'll end on this, that, I mentioned this, but we are looking and working very hard to find, this is one of many studies, but the ketogenic diet study in Alzheimer's disease is a study where we are looking at, the impact of this really pretty profound metabolic intervention of a ketogenic diet. We have reasons to believe, Dr. Swerdlow has reasons to believe this impacts the brain in a positive way. And so we're testing that idea. We have some preliminary data that suggests so. So it's a really interesting study. We need people, but we need people for a number of studies as well. You don't need to know we've got 30, 40 studies. If you want to know them, we'll tell you all about them. But just refer people on the research side, and we have a team of people who will figure out what studies they might qualify for. So, all right. So we got 5 minutes for questions, if there are questions. Let's see here. Okay, we do have a couple questions. Great. So get your continuing education. Don't forget, the activity code is in the chat. What target heart rate is best for exercise? Everybody's different, and so there's different ways to determine that. But get it above 100 and push it. And you can look up, how to determine your best target heart rate. There's a little formula, 80%, I think, of a certain number. Anyway, but push it. We tell people that sort of turn it into actionable information is just get out there and get a little bit out of breath and break a sweat. And that should get you to the right heart rate. But the more you push it, probably the better. Could the future of a medication like lecanemab be the use of this class in patients diagnosed with MI or even those whom are considered high risk? MCI, I think you mean. So the question is, could we use this drug for those at high risk? And the answer is yes. We could, and that's what we're testing in the AHEAD trial. So again, that AHEAD trial, I ran through it quickly, but that is using lecanemab for 4 years in people who have amyloid in their brain without any memory problems. Turns out about 30% of people over the age of 65 have amyloid in their brain, despite being totally normal in terms of their memory and thinking. So that we see that as a risk factor. And so we're testing that idea. All right, if we influence that amyloid, will it reduce risk for the long term for these individuals? We will know that answer at least with 2 different drugs within the next few years. One we'll learn late next year, solanezumab. We've been doing that study for 6 or 7 years, called the A4 study. And so that's a real mild form of the monoclonal antibodies. And then this lecanemab is in trial right now. So yes, someday we're going to be able to measure risk and hopefully prescribe medications, but always prescribe lifestyle and actually encourage lifestyle changes. So if another question just came in, if a parent and grandparent has had cognitive impairment and possibly Alzheimer's, would it be recommended for their adult children to be tested or enroll in studies for prevention? So number 1 there. Number 2, enroll in studies for prevention. Yes, if we have them. And then the first one, is it important to be tested? Not yet, not until I don't think, that's the short answer, is not yet until we have proven strategies for prevention, like drugs. And, so I think we have a little work to do to really prove that screening on a wide scale is really important. And that is, we need to prove we have things we can do, really actionable, targeted interventions. And when we have those, then yes, we'll start screening. And then Wichita does have 2 ongoing trials using lecanemab. So Wichita has an active research group that we collaborate with. And so if you're in the area, send your patients there. And then sleep in a patient without sleep apnea who suffers insomnia, is it better to incur suboptimal sleep duration, 3 to 4 nights per week, or to treat that with a prescription agent? Oh boy, assuming other sleep hygienes are appropriately addressed. Man, that's a tough one. And I don't know if I'm the guy to answer that question. That's a really good question. Would you rather, sleep fewer hours or use a prescription drug? Yeah, I think you're thinking about it right. The minimum amount to keep them healthy. I don't know that there's trade-offs either way. The prescription drugs are not ideal. We don't love them, and they can have an impact. But they also can have a positive impact and be used at low doses. And people, but we don't prescribe them very much in our memory clinic. So I can't say much more than that. That's not a very good answer. I don't have a sleep specialist on who wants to chime in. Okay, so we got 2 minutes. I don't know if I'm missing any questions. Whatever it takes to get someone to use CPAP. This question was without sleep apnea, but CPAP. We need to really be aggressive about treating sleep apnea. And yes, there's a lot of people who really can't tolerate the CPAP, but we really need to encourage it. And does melatonin lose its power over extended use over a time period? That's another one. I'd say stick with it because it's so, benign, and stick with it. But if people are, if it's not, I don't know if there's a reason that it loses its power, or maybe you need to bump the dose. I would bump the dose if you're seeing that. But it's ideal. There are other things you can try. Trazodone was on the list there, and that are pretty safe. But here, melatonin plus here we go. Dr. Townley's on. All right. Melatonin plus trazodone are safe from a cognitive perspective. Yeah. All the others, yeah. Over the counter, the Ambiens and all, not ideal. And that is true. So doesn't really help you in practice, but we try, and I'm sure you do too, try to minimize those as much as possible. So okay. So we'll wrap it up there, but thank you. And we did it on time. Covered a lot. So appreciate it. Stay tuned for the news. But I think very hopeful time, very exciting time. These new drugs are coming. It's a new era, I think, for dementia and Alzheimer's disease. And we're just taking our first steps into it. So exciting. Thank you.
Thanks, Dr. Burns.